عندنا آخر سيشن قبل الصلاة. بالمناسبة الصلاة عندنا موجودة، في خطيب جاي وفي مكان، وبعد الصلاة مباشرة في عندنا مناسف اليوم كاملة. طيب معنا آخر سيشن الدكتور إبراهيم العبادي والدكتور حاتم إبراهيم من مصر، الدكتور أحمد جعفر من العراق، والدكتور حسن الخطيب من فلسطين. دكتور إبراهيم بس احنا بس الوقت ليميتد. دكتور إبراهيم strict.
So we'll yes, thank you. Yeah. So we will move to the second session. I would ask the speaker to finish on their time because of the limited time, because of the break time and the mansab. We will have the first speaker talking about the acute coronary syndrome management update and role of Ticagrelor in management optimization. Dr. Qais Balbissi, well-known interventional cardiologist, University of Jordan, please.
صباح الخير جميعاً وجمعة مباركة. All right, so I would like to thank the organizing committee for inviting us. I would also thank AstraZeneca for sponsoring this lecture. By the way, in the previous session, thank you for the presenters, very amazing points. So those are the cases that require you to change your scrubs afterward. So I know it's easy to kind of go over them in retrospect, but it's really bad cases, and the fact that they survived is amazing. All right, so today we're going to talk a little bit about ACS management updates. There's some changing paradigms that we need to cover. There's the antiplatelet therapy in acute coronary syndrome, a little bit on guidelines update, de-escalation versus monotherapy, and why Ticagrelor. All right, so acute coronary syndrome. All right, acute coronary syndrome, we're all familiar with acute coronary syndrome. I'm not going to give you a lecture about the pathophysiology of acute coronary syndrome, but there are a few things that we always think of. So acute coronary syndrome is a totally different animal than stable ischemic heart disease. There's ongoing thrombosis, there's instability, there's inflammation. So we need to look for that and treat that. Second, unstable versus stable plaque. Now we have certain technologies like OCT where we can identify unstable plaque, especially if you have a thin fibrous atheroma cap. When you have that, you need to be careful, you need to be a little bit more aggressive in the treatment, and those are more challenging. Now, if you look at unstable versus unstable plaques, and the severity of the disease, which is the third concept, obstructive versus non-obstructive, by sheer number, non-obstructive lesions are more common. So since they're more common, usually it's more likely to have a non-obstructive lesion that progresses into an acute coronary syndrome. But if you have an obstructive severe lesion, they're more likely to have a thin fibrous atheroma cap, and they're twice as likely to become acute coronary syndrome. So the fact that the medical management is more important than actually stenting for acute coronary syndrome prevention. Finally, rupture versus erosion. We all know rupture is the usual common cause for acute coronary syndrome, but erosion is coming to become more frequent and more likely cause. It's probably underdiagnosed. By the way, what is the timer? So this is just a little bit of an OCT. As you can see, this is a stable plaque. There's some vasovasorum that's very obvious. Then here, this is a intramural hematoma or with a lipid core, and this is a thick fibrous cap, which is more than 65 nanometer. Now, this is considered a more stable one, while this one, which is less than 65, this is 30 nanometer, is considered an unstable plaque. It's more likely to rupture. Ultimately, it can rupture and then lead to the initiation of acute coronary syndrome. So again, acute coronary syndrome has a big burden, not only at the time of acute coronary syndrome, but they're more likely to have another MACE within 1 year. Actually, 1 out of 5 will have another recurrent event. And it increases with time. This is not just in the first year, it goes throughout. And also, the more likely you have an MI once, it happens again throughout the years and different ages. All right, so let's move to antiplatelet therapy. First of all, aspirin. We're all okay with aspirin. We all know patients should be on aspirin. This is changing a little bit, but at least at the time of onset, they need to be on aspirin, and for at least a period of a year, if not lifetime. Now let's go to the meat of the talk, which is the P2Y12 receptor blockers. We're all familiar with the classical clopidogrel one, but the problem with clopidogrel, it has two-step metabolism to become stable, and those two steps are CYP450 dependent, which has a lot of polymorphism. Polymorphism meaning, it's different genetics. You can metabolize it more or metabolize it less. So in these cases, the prodrug, which is clopidogrel, doesn't become the active metabolite. So in those cases, these patients are resistant to clopidogrel. And that's a problem which could present sometimes like the case we saw earlier. Now, they thought, so how can we fix this? So they came up with prasugrel. Now, prasugrel is only one step that is CYP dependent. The other one is hydrolysis. Until now, there's no clinically significant recorded resistance to prasugrel, but still, it's a prodrug. And both of these drugs bind irreversibly to the P2Y12 receptor, meaning once it's in there, it's there for the lifetime of the platelets. So that can become a problem if you want to have a rapid onset of withdrawal of that effect. So now comes Ticagrelor. Ticagrelor is an active drug. You give it, it gets absorbed, it works directly on P2Y12 in a reversible fashion. So that's an advantage. Now, Cangrelor technically is another P2Y12 receptor that is reversible, and it's given in IV form. And there is also Stilatigrel, which is a sub-Q form of a P2Y12 inhibitor. Now, always I say, show me the evidence, So as we said, aspirin's been proven through multiple trials. Ticlopidine was doomed by the fact that it causes leukopenia. So now comes clopidogrel, the savior. So there's CURE trial, which clearly showed the efficacy of clopidogrel and established it. But again, we had problems due to resistance. So what could we do? One thought was double the dose, current OASIS. Double the dose of Plavix or clopidogrel, maybe it helps. But it turned out that no, not really. It doesn't do the trick. So that's what pushed the envelope to kind of find another alternative, which is Triton. Triton looked at prasugrel. Now, prasugrel was a good drug, didn't have that much of resistance. Really, it was non-inferior, but also had some more bleeding. So they tried to look at different dosing, and then they also tried to look at preloading with Acost. It didn't do the trick. So then comes Ticagrelor with Plato trial. And I'm going to talk about Plato trial a little bit more. But then they also started talking about about Ticagrelor in cases of pre-treatment or Ticagrelor on long term, and that's when Pegasus and DAPT came in. So ultimately, this translated into guidelines. So the few points that I do want to highlight in guidelines, and I want to leave some room for questions, that's why I'm going to go a little bit faster, is the following. So first of all, both prasugrel and Ticagrelor are class 1 in acute coronary syndrome, regardless whether it's a STEMI or non-STEMI. Second thing is clopidogrel is indicated if prasugrel or Ticagrelor cannot be used because of the fact that, like a similar case we just talked about before, especially if you have multiple stenting, high-risk patients. Another thing is in patients who have high risk of bleeding, you could consider stopping or switching to clopidogrel at an earlier stage. Again, I don't want to bore you with too much details about this. We can all read it in the guidelines. But what I do want to bring to your point is, what is a high-risk bleeding patient? When do we actually try to think of de-escalating earlier? So de-escalation is when a high-risk bleeding patient is actually a patient who's already on an oral anticoagulant for some other reason. If he has a history of kidney disease, if he has anemia, active bleeding, or active malignancy. Otherwise, there are some combinations, whether you're on steroidals, some kidney disease, but it's not bad. Those are cases where you'd think of it, you'd consider it, but you have to have more than one to consider them a high-risk bleeding patient. Finally, as far as the guidelines, I do want to also bring to your attention that when do we not give those medications? So aspirin cannot be given in acute coronary syndrome if it hits less than 10,000, clopidogrel if it hits less than 30, and if you have a patient with the platelets less than 50, try to avoid ticagrelor or prasugrel. All right. Now, of course, we all know about the fact which one should we use more. Should we go more for prasugrel or ticagrelor? Now, there's a lot of debate. You could make an argument for both. There's trials that supports this and that. There's ISA-REACT that kind of leans toward prasugrel. But again, ISA-REACT has his limitations. It has some bias, selection bias in it. And there's also the meta-analysis, which was published in Circulation in 2020, which showed they're both equal. So both are good, reasonable options. Now, let's talk about the point of de-escalation. Okay, so the term de-escalation means trying to move from the more likely stronger dual antiplatelet medication, such as prasugrel or ticagrelor, to a less one, which is clopidogrel. Now, this has shown that it actually does not translate well. It actually causes higher incidence of NACE, both, which is the NET and MACE, in the SCOPE trial, and Lee et al. Has demonstrated the same thing. So it's not a really favorable thing to do. So what can we do? Another option is actually, rather than de-escalating from a stronger medication to a less bleeding risk medication, is to stop the aspirin, go to a monotherapy. And that has been proven to be useful, especially in the case of ticagrelor, in both TWILIGHT study and TICO study, which I'll go over in a minute. So the MACE was similar, so you're not increasing events with dropping the aspirin, and bleeding is considerably lower. And that's the same in TICO study. So now, why ticagrelor? The Plato trial, always show me the evidence. Plato is very clear, it reduces, and it was superior actually to clopidogrel, and it reduces the events, both and mainly CV death and MI events, so it works. And it reduces instant thrombosis, which is a major nightmare, as you can see in the case before. And it is safe. It didn't translate to an increase in major bleeding. Other things that are useful also is the fact that it works for both elderly patients and for patients who have renal impairment. So the safety profile is across multiple comorbidities. And it is a good, effective drug with lower risk of complications. Now, the Achilles tendon sometimes of ticagrelor is dyspnea. But that's, again, manageable. A lot of patients will actually grow out of it. If they continue to have it, there are some tricks to help with it. And by the time, a month or two has passed, usually it's safe to change. All right. So this has not only shown to be true in trial state, it has also translated into real-time life in the Sweetheart registry. Second, good thing about ticagrelor, it's clinical pharmacology. It's an active drug, doesn't need to be activated. It has reversible binding, so if you need to stop it, it goes out of your system. You don't need to wait for the whole life of the span of the platelets. And finally, there's no CYP450 activation, which means less drug-to-drug interactions, creating a good onset offset, and that was proven in the onset offset study, which showed that it could be a shorter duration of stopping and you're actually in the clear, so less bleeding. And I'll talk about this in a minute if we have time. about the guidelines, why it translates only to 5 days, while actually it could be stopped earlier. Ultimately, also the point that we said, one of our earlier colleagues mentioned with Ticagrelor, you have less slow flow phenomenon because it actually increases adenosine in the circulation, and that creates more macro vessels dilatation, microvasculature dilatation. So ultimately, Ticagrelor is a good option for all spectrum of ACS, STEMIs and non-STEMI. It helps, it can be used in medical treatment only. Pegasus trial showed that. It can be used across different patient profiles. Plato showed that. And it is safe in elderly and stroke patients. Thank you very much. I believe that's time.
Thank you, Dr. Qais.
Thank you for this nice and informative presentation, Dr. Qais.
Thank you.
The second lecture, discussion after
Sounds good.
session.
Yes.
Sounds good. Thank you so much.
The second lecture, Dr. Janaka from UK, new strategies to improve cardio-renal outcome in people with CKD and heart failure, sharing experience and learning from London.
Dr. Janaka? Okay.
So thank you for the introduction and the opportunity to speak to you all about new strategies to improve cardio-renal outcomes in people with CKD and heart failure. These are my disclosures. A bit about where I work. This is a picture of my hospital more than 500 years ago, Guy's Hospital in London. And the hospital has changed over the last centuries. I now work at Guy's Hospital, which looks like this. It's slightly different in terms of its structure. This is the Shangri-La Hotel, owned by the government of Qatar. And here at Guy's Hospital, I do clinics for people with kidney disease and diabetes, more advanced kidney disease. And we do about 250 kidney transplants a year. I also work at St. Thomas's, where we do clinics for people with cardiovascular disease, mainly heart failure and cardiovascular disease in people with type 2 diabetes. So what I want to talk about is why cardio-renal-metabolic system interaction is important, the key role of SGLT2 inhibitors to prevent cardiovascular disease and heart failure, summarize the important results from EMPA-Kidney, the largest SGLT2 inhibitor trial in people with CKD, and then share some practical clinical experience from my experience working in London. So many people with diabetes will develop kidney disease, many people with chronic kidney disease will develop heart failure, and many people with heart failure or cardiovascular disease will develop diabetes if they don't have it already. And what's important is that these three conditions are interconnected, and our patients will often have common comorbidities like heart failure and CKD if they have type 2 diabetes. But if they have heart failure or cardiovascular disease, the patients you see, very often they will be having chronic kidney disease and type 2 diabetes. And these interactive systems are interrelated. The heart is symbiotic with the kidney. If the heart is damaged or not working, the kidney is damaged and not working. If the kidney is damaged and not working, the heart is going to be impacted. And they're almost like two partners in a marriage. If one is unhappy, the other one will be unhappy. And it's about thinking of this interrelationship between the heart and the kidney, which is very, very important, especially when you have conditions like diabetes, which makes everything worse in terms of kidney disease as well as cardiovascular disease is enhanced when you have type 2 diabetes also in the mix. And if we have a patient, we know that they have many common comorbidities, as I described. And what is important is that we can now all work better together because we have SGLT2 inhibitor treatments that can actually bring specialists together and put the patient right at the center in terms of offering them a treatment. Even in people without diabetes, we can treat people with heart failure and CKD with an SGLT2 inhibitor, but specifically in people with diabetes who develop heart disease or at high risk of cardiovascular disease or at high risk of kidney disease, we can offer SGLT2 inhibitor, which actually puts the patient at the middle and brings all these specialists together to work as a team. Kidney disease is important. And the key message here is about early identification of CKD. When we diagnose and classify CKD, we use estimated GFR from serum creatinine, but also albuminuria. And if you do not do the albuminuria testing, you will miss people with a GFR above 60 who have early stage CKD. But even if the GFR is below 60, you can see that the presence of albuminuria can increase your risk from moderate to high to very high. And this risk is not just kidney failure, but also cardiovascular disease. The more red you have means you also have a high risk of dying of cardiovascular disease, because CKD is an independent risk factor for mortality, but albuminuria is also a very powerful risk factor for heart failure and cardiovascular disease. And how are we in terms of monitoring kidney disease? We're not very good. This is a picture of an elegant physician 600 years ago showing the importance of urine analysis. And here he's looking at a urine flask made out of leather. It's an accoutrement, like a fashion accessory, like a modern Gucci bag or a Chanel bag. But in this leather flask, he's looking at urine. And urine is a window into what is happening inside your body. And by looking at urine, you can identify many, many diseases. And we know that in early stage kidney disease, the rise in proteinuria, the rise in albuminuria precedes the drop in kidney function. So before the GFR drops, you have albuminuria picked up as a urine albumin creatinine ratio rising. And most importantly for all of you as cardiologists is that albuminuria is also a marker of vascular dysfunction, of endothelial damage, endothelial dysfunction. And a rise in albuminuria is also a very powerful marker for cardiovascular mortality, but also specifically for heart failure. And in our heart failure clinics, we're measuring urine albuminuria because it's a very powerful marker of heart failure hospitalization. So how are we at diagnosing people with CKD? This is data from the US, but sadly, it's the same in many parts of the world. We're very bad because we are not doing the urine ACRs. We're missing the diagnosis at early stage CKD. Patients are not getting their urine ACRs. And often, even if they're diagnosed, they're not being coded correctly. And most patients are sadly diagnosed when they're referred at stage 4 or 5 when it's too late. So doing those urine ACRs is so important to diagnose people early and to confirm the diagnosis and start treatment. Serum creatinine is done in many parts of the world, but it's not very accurate compared to estimated eGFR, which takes into account the age and the gender of the person. And here we have two people who look very different with the same serum creatinine, but they have very different eGFRs. And we must always do the estimated GFR and not rely on the serum creatinine, because the eGFR is much better and more accurate. And we must also look at the trend, looking at the past values to identify people who are stable, but also people who are dropping fast with a decline in kidney function. So we have to check the urine. We have to do the urine ACR, the albumin creatinine ratio, because if you can identify people early, you can treat them before they get worse heart failure, worse kidney disease, develop cardiovascular disease. And we now have the opportunity with drugs like SGLT2 inhibitors to treat people early with cardio-renal-metabolic disease or early CKD. Many people in your clinics will have hypertension, and actually hypertension is a very high risk factor for chronic kidney disease, more powerful than diabetes. And if you have diabetes and you get hypertension, your risk of kidney failure is very, very high. So when you have your patients with hypertension, please check the urine ACR for albumin creatinine ratio. Please do the serum creatinine and get the eGFR, because those hypertensive patients are those at very high risk of kidney disease, but also of stroke and heart failure. But identifying kidney disease is key in the patient with hypertension. So please don't forget to screen the hypertensive patient for end organ damage, looking at albuminuria as a marker on risk factor for kidney disease as well as cardiovascular disease. And here you can see the different stages of CKD, and depending on the stage of CKD, you will treat, and the treatment is RAS inhibition, statin for cardiovascular disease, and SGLT2 inhibitor. And if you're worried about progressing decline in kidney function or heavy albuminuria, treat and refer to the nephrologist for further advice and guidance. And if you have young type 2, this is a very high-risk population. The key message from this slide is that if you have young diabetes, type 2 diabetes, and early CKD, you're losing nearly 15 to 20 years of life. And I will say early CKD, this is proteinuria without a significant decline in eGFR. The youngest patient I have on dialysis due to type 2 diabetes is in their 30s. If you go to the cardiovascular coronary care unit, you will see a lot of young type 2 diabetes in any center around the world. So young type 2, where people get type 2 diabetes in their 20s or 30s, it's a very high risk for kidney disease, but also for cardiovascular disease and mortality. And we are now fortunate that we can use empagliflozin, which has got benefits for insufficiently controlled type 2. What do we mean by that? It's not just the HbA1c, it's actually preventing cardiovascular events. So even if the HbA1c is 7% or 6.5%, we will treat the patient with Jardiance to prevent their future risk of cardiovascular disease. It can be used for chronic kidney disease in people with and without type 2 diabetes, and all of you know about the data for heart failure across a range of ejection fractions in preventing hospitalization, but also preventing kidney disease progression in people with heart failure. For CKD, we have a multifactorial approach with good glucose control, but being cautious to avoid hypoglycemia in advanced CKD, good blood pressure control, lifestyle with good exercise, diet, and preventing high intake of salt, good doses of statin to prevent cardiovascular disease, prevention of smoking, and now we add SGLT2 inhibitors on top of an ACE inhibitor or an angiotensin receptor blocker to prevent kidney disease, but also protect from cardiovascular disease. So for kidney disease, unlike cardiology, we haven't had many new drugs for 20 plus years, but like waiting for buses, these buses didn't all come after 20 years in London, but here we see SGLT2 inhibitors right at the front as a treatment we can offer on top of RAS inhibition to treat patients with kidney disease, but also to prevent their risk of cardiovascular disease and heart failure. We have finerenone and GLP-1s, which are also now indicated for CKD, but SGLT2 inhibitors are the first-line therapy after RAS inhibition for people with CKD and type 2 diabetes. The EMPA-KIDNEY study is the largest SGLT2 inhibitor study done, and empagliflozin 10 milligrams was added on top of standard of care. What is standard of care? It's RAS inhibition. And compared to placebo, it had a composite endpoint of kidney disease progression, needing dialysis or a drop in GFR below 10, or ESKD, or renal death, or cardiovascular death. So it was a composite endpoint. The population was unique. It was people with a GFR of 45 to 90 with raised albuminuria, but also for the first time, population without albuminuria, but who had CKD with GFR 20 to 45. People with recent cardiovascular disease and good kidney function were excluded. And generally, this was a low cardiovascular risk population compared to many other studies. And here you can see Credence, which is the first study with type 2 and heavy proteinuria. DAPA-CKD was mainly type 2 with GFR 25 to 75 with heavy proteinuria, but EMPA-KIDNEY included people with no proteinuria but with CKD, but also is a larger study with a large number of people without type 2 diabetes. But right down to a GFR of 20, all the way up to a GFR of 90 with and without type 2 diabetes, the broadest population, the kind of patient with CKD that you will see in a cardiology clinic or an internal medicine clinic is the EMPA-KIDNEY patient. And you can see here that a lot of them had a low eGFR below 30, a large number had low proteinuria, and many of them did not have diabetes. So this is a low cardiovascular risk population compared to Credence or DAPA-CKD with lots of hypertensive kidney disease, but also advanced CKD. So a high kidney population, but a relatively lower cardiovascular risk population compared to the proteinuric type 2 study populations in DAPA-CKD and Credence. And if you look at the primary endpoint, there was a 28% risk reduction. The study was stopped early because of the benefits. It was meant to run for more than 3 years, but it was stopped early after a median follow-up of 2 years with a number needed to treat of 28 on top of RAS inhibition, but also other drugs like statins. So a very significant benefit with empagliflozin in patients with CKD. What was the composite driven by? It was kidney failure, because as I said, these were patients with low GFR who were progressing to kidney failure, and by preventing dialysis, the study had to be stopped because you were preventing dialysis. If you end up on dialysis, this is almost like a death sentence, because most patients who end up on dialysis will die within the next 3 to 5 years. So the study was stopped early because of the benefits for preventing dialysis, and the study could not be kept going waiting for cardiovascular signals because of the clear benefits for preventing dialysis in this population with CKD. And in addition, there was benefits for slope, where we prevented the fall in eGFR by nearly 50%, preventing the decline in estimated GFR across a range of patients with CKD with and without albuminuria. There was a significant delay in the drop of eGFR, which is very important with empagliflozin compared to standard of care, which is RAS inhibition in placebo. And if you look at all the trials for CKD, all of them are very similar. EMPA-KIDNEY is the shortest because it was stopped early, but also the largest, but had more people without diabetes. But overall, very similar results for kidney disease outcome, but none of these studies actually prevented cardiovascular mortality because they were kidney studies and they included a kidney outcome as part of the composite. And when you see a signal for preventing dialysis, you have to stop the study rather than waiting to see if other cardiovascular signals will emerge later on. A key benefit of empagliflozin in the EMPA-KIDNEY study is preventing hospitalization, which is so important. It's expensive to patients, but also expensive to healthcare systems. And here we have a unique indication in the US for also preventing hospitalization. So it has a license for cardiovascular mortality in type 2 diabetes, heart failure, and prevention of kidney disease, but also for preventing hospitalization, which is a key treatment objective for all of us looking after patients with diabetes and CKD, with the impressive number needed to treat of 23 over 2 years to prevent any hospitalization in people with chronic kidney disease. The side effect profile and safety profile was reassuring and very similar to what we know about the class, with no increased risks of severe dehydration, hypoglycemia, or any other adverse effects as compared to placebo. We know about the benefits for cardiovascular mortality. All of you know about the seminal results of EMPA-REG outcome, the only SGLT2 inhibitor to demonstrate reduction in all-cause mortality and cardiovascular death in people with type 2 diabetes with elevated cardiovascular risk, the kind of patients you'll be seeing in cardiology and lipid clinics. And these benefits were seen in people with preserved kidney function, to those with more advanced kidney disease, in people with and without heart failure. So clear benefits to reduce cardiovascular mortality on top of ACE, on top of statin, on top of beta blocker, on top of antiplatelet therapy. You get good benefits for cardiovascular mortality. And the message from this slide is to treat early and to get the benefits early for patients with diabetes. And why do I mention it? Because the benefits are seen within 59 days. And if you treat people early, you prevent mortality signal and you see the benefits within 60 days. If you wait 6 months, you're causing harm because you're denying the patient the benefits of the drug, which works at 59 days for mortality. But as you know, for heart failure, works within 2 weeks. And that's why we are initiating these drugs in hospital to prevent mortality, but also prevent hospitalization in people with heart failure. Heart failure, you're very familiar with all the data. I'm not going to go through it. A license for a range of ejection fractions, but importantly with the MPulse data, a reduction in 36% of hospitalization and other events accrued with benefit in people with stable heart failure after admission with an acute heart failure event. And here we see the data for heart failure across the range of ejection fractions from Emperor reduced to Emperor preserved in people with and without diabetes, with and without CKD. And the key message is the benefits are seen within 2 to 3 weeks. So starting the drugs early once the patient is stable is so important to get the benefits for heart failure hospitalization. And the benefits are seen so early that this is important why we need to start these therapies early. And at least in London, we're starting these therapies immediately once the patient is stable after their hospitalization. And in addition to the benefits of heart failure hospitalization, you get benefits for kidney disease. Patients with heart failure have a rapid progression of kidney failure. And here you get the heart failure hospitalization benefits, but also you get a slowing of the kidney function decline. So you're preserving kidney function and maintaining the kidney life of the patient. And that's really important, especially in patients with heart failure. What about the acutely heart failure patient who is admitted with decompensation? What can we do when the patient is stable? The stabilization criteria for MPulse was a stable systolic blood pressure, no need for a rise in IV diuretics or no IV vasodilators and no inotropic support for 24 hours. And if the patient fulfilled all these criteria, they were started on empagliflozin 10 milligrams, which demonstrated benefits in terms of preventing hospitalization for heart failure and a series of other important clinical endpoints. What about screening? Again, I think in cardiology, you're very good at doing this, but this is a slide more for diabetes doctors, internal medicine doctors, especially for heart failure with preserved ejection fraction, to have a scoring system and ask about symptoms, but also diagnostic workup and NT-proBNP, which according to the UK, because of our kind of National Health Service, we stratify patients depending on the NT-proBNP for urgent review or for people within 6 weeks, for people with less severe raised NT-proBNP. But in obese people with type 2 diabetes who have these risk factors, we should be screening for heart failure with preserved ejection fraction, especially if they have symptoms. And by asking about symptoms, we may be screening more people who have HFpEF, especially with diabetes, obesity, and CKD. Some practical considerations to wrap up the talk. We need to be cautious in the very elderly, but please remember there are lots of 80-year-olds who are independent, who are living at home, who are at high risk of cardiovascular disease and heart failure. And in those patients who are not frail but independent, I would be treating with SGLT2 inhibitors. I have 80-year-olds on SGLT2 inhibitors because we want them to stay independent and stay out of hospital. We are cautious in type 1 diabetes, people who have pancreatic disease or severe foot sepsis or ketogenic diets. We worry about thin people who are losing weight because they're insulin deficient. We worry about DKA. When people are acutely unwell, we will pause the drug, and we often pause the drug before major surgery and restart it. But if the patient comes in with acute heart failure, we actually continue the drug in London and don't pause it at all. We just continue the drug in acute heart failure. But in other situations of medical emergency, we pause the drug and restart it 24 hours prior to discharge when the patient is ready to go home. We give all our patients these sick day rules about what to do when they're acutely unwell at home. If they have severe vomiting or diarrhea and they cannot take their medication, we give these little guidance where a pharmacist or an educator goes through the medicines to pause the medicine for 48 hours, wait till they're eating and drinking normally, and then restart the medicines. And every patient gets a little card like this in my kidney clinic and heart failure clinic about pausing, but also importantly, restarting straight away once they're able to eat and drink normally, especially if they've had severe diarrhea and vomiting. It's okay to pause, but most importantly, restart the drugs within 48 hours once they're feeling better. A quick guidance for heart failure clinics in terms of patients with type 2 diabetes. This is what we've shared with our heart failure team. If the patient has an eGFR over 45, the SGLT2 inhibitor can lower glucose because this is dependent on kidney function. So you ask the patient, are they on insulin or SU? It's no. You start the SGLT2 for heart failure or CKD. That's the indication. If the patient is on insulin or SU, you ask, are they if it's yes, we ask for an A1C. Now the heart failure clinic does an A1C now. If the A1C is over 8%, we add the SGLT2 inhibitor. If the A1C is below 8%, we add the SGLT2 inhibitor, but we tell the patient to monitor the glucose and to reduce the dose of gliclazide or insulin if they notice blood glucose levels that are dropping. If the patient has a GFR below 45, the drug will still have benefits for the heart and the kidney, but will have no benefits for lowering glucose. So whether the patient is on an insulin or sulfonylurea, it doesn't matter. We just add the SGLT2 inhibitor because we're giving the drug for the heart failure and kidney benefits in patients here in this scenario. So why do we need to act? This is a picture of a patient over time. This is their kidney function that is dropping. We did MDRD in the beginning, but now we use CKD-EPI, as you know, and he goes to all these clinics And you can see that the number of visits go up, the cost to the NHS, which is a public healthcare system, goes up. He ends up on dialysis a couple of years ago, and this year he got a transplant. So his costs have gone up even more than what's shown here. But the reason I show is that when he's referred to me in 2019, it's too late. And what we need to do is treat these patients early to prevent the progression of their kidney disease, but also the cardiology complications and the heart failure complications that happen in many patients with kidney disease. If you remember this picture, this is the Shangri-La Hotel and the Guy's Hospital next to each other. This is the view from the Shangri-La Hotel. It's a 5-star hotel overlooking London. And one night at the Shangri-La is $750 with amazing Michelin-starred restaurants and butlers. But actually, it's more expensive to the public healthcare system if you spend one night at Guy's Hospital, which is not as beautiful by any means, and you do not get a Michelin-starred menu, but it's more expensive. And the reason I put this, it's not just the economic cost, but also the human cost, which we cannot put a number on. And preventing hospitalization is so important for our patients, but also for the healthcare economy, because people pay either through insurance, pay out of pocket, or pay through taxation. And eventually someone pays for these hugely expensive complications, which we should treat early to prevent from happening or progressing. So most patients with type 2 diabetes, if you see them in the clinic, you'd give them a statin, you'd give a statin for someone post-MI. And in my opinion, we should be thinking that this should be the default. Why is this patient not on the drug is what we should be asking. We should be giving everyone SGLT2 inhibitors if they have elevated cardiovascular risk, which most people do with type 2 diabetes, if they have CKD or with heart failure. This is class 1A evidence, and we should be offering this drug to most of our patients we see in clinic. And why do we need to start the drug early? Here you have data from EMPA-Kidney that if you start the drug with a GFR over 80, you can get 27 years without needing to go to a kidney doctor or even develop kidney failure. If you start the drug at a GFR of 20, you get 2 years. So it's still good. You're still getting some extra time. So it's never too late to start the drug, but it's always better to be early. And by starting the drug early, you can give extra time for our patients to do what really matters to them. And by preventing complications, improving their quality of life, we are really making a difference. But starting early is so much better than waiting to start late. It's never too late, but please start the therapy early to give the best value for our patients in terms of preventing complications. So many patients with diabetes and chronic kidney disease have silent disease. They are asymptomatic. So please screen those urine tests, do the urine albumin creatinine ratio to identify people early, but then treat early, because these drugs work quickly. Within 59 days for mortality, within 2 to 3 weeks for heart failure are the benefits of empagliflozin, which is clear in people with and without diabetes for preventing heart failure, hospitalization across a range of ejection fractions, preventing kidney disease progression in people with and without type 2 diabetes, but also preventing mortality. It's the only SGLT2 inhibitor to prevent mortality in people with type 2 diabetes at cardiovascular risk. So starting these treatments early can make a huge difference and improve the outcomes for our patients. Thank you so much for your time and attention listening to me speak today. A huge difference and improve the outcomes for our patients. Thank you so much for your time and attention listening to me speak today.
Thank you, Professor Janaka. We will take only one question. Please, Dr. Raed. Dr. Ayman, one question only, please.
Thank you for the very eloquent talk. My question is about, we talk about microalbuminuria. Should we be talking about nanoalbuminuria? And how much expectation when we add ARB and SGL2 inhibitors we should expect? I know you spoke about the creatinine. How much of a bump should we be okay with? And my last point is, we know SGLT1, they are more in the gut, and they are known to reduce the gut-derived uremic toxins, which will improve the kidney. What's your take on that? Thank you.
Yes? Okay, I think we are offline. Okay.
Will talk recorded ولا off?
He was waiting for a questions. So we'll go to the next speaker, Dr. Eyas, well-known interventional cardiologist. Please.
شكرا وصباح الخير. طبعا انا دكتور ابراهيم عبادي انا وياه صحبه
حلزم الوقت. 20 minutes أنا هحكي لكم 5 أبيات شعر وبعدين 14 minutes توك وبنكون خلصنا. أول شيء بشكر بورينجر على دعوتهم على الحديث على تريال معينة. طبعا احنا ما بنقدرش يعني دائما ننسى الواقع، فلازم نحكي شوية بيوت شعر عن غزة، كلنا منزعجين ولازم لايف جوز اون. بس تاني البرغوثي عنده شوية قصائد حلوين على الموضوع بوصف فيها القوة والشكيمة والإصرار اللي احنا عم نشوفه رغم كل المآسي. بقول لك نقاتلهم على عطش وجوع ونكران الأقاصي والأداني، نقاتلهم وظلم بني أبينا نعانيه كأننا لا نعاني، نقاتلهم كأن اليوم يوم أخير ما له في الدهر ثاني، بأيدينا لهذا الليل فجر وشمس لا تفر من البنان، بيان عسكري فاقرؤوه فقد ختم النبي على البيان. زقفوا عشان نبلش المحاضرة. شكرا. هلا نحكي على الموضوع الأقل يعني تنشن. الامبلس ستدي هي يعني شيء أنا بدي أحكي عنه اليوم، وهو الميسنج لينك بموضوع الهارت فيلير. امبارح سمعتوا عنه شوي من دكتور زاهر. أنا من أنصار خير الكلام ما قل ودل، فستريت تو ذا بوينت. ليش بدنا نعمل الامبلس ستدي؟ لأن المرضى الهارت فيلير بفوتوا عندك على المستشفى اوكي، بتعالجهم بتحسنوا وبعدين بيروحوا على البيت. بالفترة هاي بعد الديسشارج هاي فترة خطيرة، لأنه ري ادميشن حيلزم ثلثهم خلال 2-3 حيروح المريض يغيب شوي يرد يرجع لك. والمورتاليتي تبعت acute heart failure is 1 month in 1 month is about 10%. يعني بمعنى آخر هذا المريض اللي انت شايفه قدامك دخل على المستشفى اليوم بهارت فيلير 10% chance of dying خلال 1 month. فهاي مشكلة، والمرضى هدول يعني زي قنابل موقوتة. الانمت نيدز بالهارت فيلير acute heart failure هي انه معظم الدراسات انعملت على مرضى تعالجوا وطلعوا من المستشفى بعد كذا اسبوع بلشوهم، وبالتالي هدول المرضى بضلوا يرجعوا for rehospitalization. the number one for admission بالمعظم العالم بالناس الالدر اللي هو هارت فيلير، لانه هدول المرضى اصلا رايحين جايين على المستشفى. ودائما if you initiate in hospital بروتوكول للمرضى بضلوا ماشيين عليه. المريض بيعتقد انه الدواء اللي بتعطيه بالمستشفى انت هو العلاج المضبوط، هاي وصفتي اللي بدي امشي عليها. فان هاوس initiation of therapy مهم جدا، لانه it has to do with long term adherence. المريض بضل ملزم بالدواء long term اذا انت بلشتوا على الدواء بالمستشفى. الدراسات تبعون الامباجليفلوزن امبرر ريديوس وبريزيرفد فرجوا انه في early benefit خلال 2-3 بصيروا الكيرفز are separating، وبالتالي the earlier the better. بس الامبرر ريديوس او بريزيرفد استنوا few weeks بعد الاكيوت هارت فيلير بالمريض صار ستيبل بعدين بلشوه على الدواء. ففي عندك جاب بين الاكيوت ادميشن للديسشارج وبعدين بعد الامبرر. عشان يغطوا هذا الجاب الميسنج لينك عملوا الامبلس عشان تعبي هذا الفراغ. فالامبلس هي دراسه ديزاين سبيسيفيكلي عشان تشوف شو بصير when you initiate الثيرابي بالمستشفى وتعمل فولو اب ل3 أشهر. الديزاين زي ما توقعتوا حيكون انه مرضى داخلين بالمستشفى stabilized acute heart failure compensated، وبعدين بعد ما تكون امورهم هديت ويوم يومين 3 بالمستشفى they're randomized to empagliflozin 10 او بلاسيبو، وبعدين followed up primary endpoints العاديه death heart failure events time to heart failure events. ومهم جدا الكانسر سيتي كويشنير اللي هو كيف المريض حاسس، خف الشورنس اوف بريث، صار يمشي احسن، شعوره احسن. هاي الفاريبلز اللي بيهموا المرضى مع شويه سيلكتد سكندري اند بوينتس هنحكي عنها بشكل سريع. هلا طلعت هون على الاوفر ريفيو اوف شو بنعمل، استعملوا شيء بسموه وين ريشيو. الوين ريشيو هي طريقه نسبيا جديده عشان نطلع على statistics، وبستعملوها بالدراسات اللي بيكون العدد صغير، يعني 530 مريض هون بكل الدراسه، نصهم هون نصهم هون. فعملوا شيء اسمه وين ريشيو. وين ريشيو هي بتقارن المريض من هذا الجروب مع المريض من هذا الجروب، بتشوف شو احتمال يصير مع هذا مشكله مقابل احتمال يصير مع هذا مشكله، يعني زي كانه فريقين بتناوبوا بس طلع فرد فرد. والوين ريشيو هي قديش فوز الامباجليفلوزن اوفر قديش فوز البلاسيبو. وفي عندك على الشمال هون الطريقه التسلسليه في النظر للموضوع. تطلع على الديث اول شيء، اذا ما في حدا سوبيريور تنزل على النكست ستيب هارت فير ايفنتس، ما في حدا سوبيريور بتشوف تايم فور هارت فير ايفنتس، ما في حدا سبيرير بتروح على كانساس سيتي. بس في النهايه بيطلع عندك احصائيات بتشبه اللي احنا فاهمينه من اول ولكن بتويست خفيف نسبيا. بعض الناس لما يطلعوا عليها بيلتخموا شوي لما يشوفوا الوين ريشيو، بس في النهايه هي it makes يعني the same conclusions. اذا طلعت هون مثلا على الكرايتيريا فور الامبلس البرايمري اوتكم، كان في اكثر من شغله، وهي انه احنا بنطلع على المرضى اللي عندهم يعني فور شور هارت فيلير، لازم يكون مريض عنده كونجستشن بيرزيستنت ديسنيا، عنده لور لمب اديما، مش سي او بي ديرز يعني. فحطوا كرايتيريا سترينجنت تو شو انه ذيز ار كيوت هارت فيلير فعلا، واشترطوا برضه يكون الانتي برو بي ان بي 1600 اذا مريض سانس ريدم او 2400 اذا مريض افب. فبدهم هاي ريسك بيشنت، بدهم هاي انتي برو بي ان بي على اساس انه يصير ايفنتس. اذا طلعنا على الاوتكم يعني بعد الاستابلايزيشن، المرضى لازم هم يكونوا اولا شويه يعني نصبر عليهم ضغطهم يكون فوق ال100، ما يكون عندهم هايبوتنشن او ديزنس، بشرط يكون عندهم ما في انكريز بالاي في دايوريتكس ان ذا لاست 6 اورز، يعني المريض يكون ماشي على ستيبل دوز اوف دايوريتكس على الاقل 6 ساعات، وما يكون ماشي على اي في فيزو دايليترز ل6 ساعات، وما يكون ماشي على اي في اينوتروبز اتليست فور 24 اورز. فيعني مريضك بالسي سي يو دخل ليله بلشته مثلا على اي في ناتريتس ضغطه عالي، او بلشته على اي في دوبيتامين او دوبامين، بده يكون اوف الحكي هذا 24 ساعه، يكون على ستيبل دوز اوف دايوريتكس. الافيكاسي اوتكم اللي هي المين ريزلت، احنا حكينا اطلعوا عليها بموضوع الوين ريشيو. طلعت فوق على الشمال الكلينيكال بنفيت 53% او 54 تقريبا من الامباجليفلوزين اتشيفد كلينيكال بنفيت مقابل 39، فمريضك احتمال انه يستفيد كان 54% بالامباجليفلوزين مقابل 39 بالبلاسيبو. يعني الامبا فاز 54% من الوقت والبلاسيبو فاز 39. كانوا تايد يعني تعادلوا ب 6%، فكان في 36% مور تشانس انه المريض يتحسن على الامباجليفلوزين، وهذا ريتش statistical significance، البي فاليو كانت significant. فهذا اول شيء البرايمري اند بوينت واز ميت. فطلع تحت على الديث time to death او number of death was reduced by half. بالامبا جروب الابسولوت نمبر 11 واحد ماتوا من 230، بالبلاسيبو 22 واحد يعني دبل، وبالتالي كان 50% less death. بس لانه small number of patients ما نقدرش نحكي انه 50% mortality reduction، but this is clearly يعني something that encouraging. الشيء المهم جدا برضه الكانساس سيتي كويشنير اللي هو الكي سي كيو كان برضه واضح جدا towards الامباجليفلوزين احسن، يعني الرقم كان عالي، بالتالي المرضى they felt better، وهذا مهم جدا بالمرضى اللي بيدخلوا على المستشفى، باخذ دواء بروح تحسن عليه حيكملوا، ما شعرش فرق الدواء did not make a difference مش حيكملوا. فالمين ايفنتس الكومبوزيت اند بوينت الديث ريت واز ريديوسد، والكانساس سيتي the way they feel was also reduced، فالافيكاسي was achieved. الكلينيكال بنفيت بهاي الدراسه زبطت regardless المريض كانوا دي نوفو هارت فيلير يعني جديد هارت فيلير، او كرونيك ديكومبنسيت يعني مريض اذا جاك اول مره بتشخص هارت فيلير، او من اول معروف هارت فيلير وجايك ديكومبنسيشن ذا سيم ثينج. فالبنفيت did not make a difference. والبنفيت برضه regardless of the EF، اذا طلعت على السب جروب اناليسيز whether you have an EF below 40 above 40 whether you have HFrEF او HFpEF بهاي الجروب صحه صغيره the benefit was there. فالمرضى بدخلوا لك بهارت فيلير على المستشفى، اذا بلشتوا على الامبا بغض النظر عن الاف تبعه he will derive benefit based على الامبلس ستدي. سيفتي وايز حامشي عليها سريعا، ما كانش في اي الارمينج سيجنال لسيفتي، بالعكس الادفيرس ايفنتس كانوا بشكل عام اقل مع الامباجليفلوزين، الادفيرس ايفنت ليدنج تو ستوبينج ذا ميديكيشن كانوا اقل مع الامباجليفلوزين، فما كان في السيجنالز اللي بنعرفهم عاده. الشيء البوزيتيف الكويس اذا بتطلع هون بخط كبير acute renal failure was less with empagliflozin، هايلايتنج اللي حكاه السبيكر اللي قبلي على موضوع الكدني بروتكشن. حتى ب one period of 3 months follow up كان في بروتكشن وليس رينال فيلير بهدول المرضى. ومرضانا اللي بخشوا هارت فيلير they're more likely بتعرف مرات تخربط الكدني فانكشن تبعهم، فيكون عندك دواء بخفف احتمال يصير acute renal failure is a good important finding. طلعت هون على الفاريبلز الثانيه اللي طلع عليها شويه كيمستري وما شابه، no real difference. الجي اف ار زاد 1.9 بالامباجليفلوزين مقابل 1.1 and this is important. هذا ال 0.9 مهم ب3 اشهر لانه على المدى البعيد builds up على cumulative kidney protection، وبالتالي الدواء مفيد للكلى ومفيد للقلب. باختصار السمري اوف ذا امبلس هو انه مرضانا اللي بفوتوا على المستشفى بهارت فيلير they have a high incidence of rehospitalization. empagliflozin بيقلل هذا الريسك سواء مرضى دي نوفو او acute decompensated by 36% benefit when you started acutely in the hospital. This benefit was observed regardless of HFpEF or HFrEF. مرضى عندهم EF عالي او واطي it's the same. والافيكاسي اوتكم كانت ممتازه بدون ما يكون في عندك شيء حساب السيفتي. فالسيفتي was there with the point انه you have less acute renal failure بالامبلس. فالامبلس عبت الجاب وصار في عندنا انديكيشن والجايد لاينز تغيروا انه initiate therapy بالمستشفى بالفور بيلرز اوف هارت فيلير وباس جي ال تي 2 بهاي الحاله جارديانز او امباجليفلوزن ان هاوس سواء المريض هيفبف او هيفرف. الدواء الوحيد اللي ممكن تستعمله انت لما المريض يكون داخل المستشفى بهارت فيلير بدون ما تكون عارف الاي اف تبعه من اولها هو ان اس جي ال تي 2 بحسب الجايد لاينز والامبلس كونفيرمز هذا الكلام. وشكرا جزيلا لاستماعكم.
شكرا دكتور إياس على البرزنتيشن الرائع about impulse trial, and now we can go.
Thank you for all presenter. Now we can open the discussion and the question. If anyone, yes, please. Microphone.
I have a comment, Dr. Eyas. Thank you for a nice talk. That we have to emphasize that treatment of heart failure is really a multifaceted treatment. It's not just take the pill and go home. We have to spend some time with those patients. We have to teach them about diet restriction, sodium restriction, fluid restriction, exercise, stop smoking, take your medication, cut down alcohol if you're drinking. In one study, and as you said, we have heart failure is the only diagnosis that's on the rise, and it's really causing a lot of financial burden in many countries. And in one study, they found that the only single factor that reduced, besides compliance with medication, heart failure rehospitalization was a phone call from a healthcare provider within 1 week of discharge. I mean, I used to tell my patients, you go and eat one Chinese meal with this high salt in their, I don't know what you call it.
Soya sauce.
Yeah, I will see you in the emergency room that night, and that's a fact. And I think we should approach it in a multi-factor issue. We should have heart failure clinics. These patients should be really seen by a specialist, because otherwise they will keep coming back, and every time they come back, you know, they will have a risk of having even in-hospital infection.
Absolutely, I agree 100%. أعتقد موضوع الهارت فيلر كلينكس مهم لو يصير عندنا أكثر وأكثر في البلد، لأنه هذا مهم جدا. موضوع الايرلي فولو اب 100% ضروري. احنا مرضانا اللي بيدخلوا عندنا اكيوت هارت فيلر بنقول لهم تعالوا بعد اسبوع نشوفكم بالعياده، نتاكد انهم كومبلاينت والدواء مضبوط وما نسيوش نص الدواء بالبيت، وعشان تو ادجست الدايوريتك دوزج ونتاكد انهم كومبلاينت. بس هارت فيلر كلينيك از ديفينتلي اي ماست ونيد، واعتقد بعض المحلات بلشوا يعملوها، بعرفش اذا الجامعه عندهم اياها. اذا قيس بيقدر يعلقنا على الموضوع، او اذا التكنو عندهم اياها. العبدلي كان عندهم واحده بس ما اعتقدش انه يعني توك اوف. بس وي نيد هارت فيلر كلينيك لانه بدك مالتي ديسبلينري، بدك نيرس. النيرسز مرات بصيروا اشطر منا بموضوع الاديوكيشن والتريننج والتعليم للمرضى.
Dr. Yes, we in بالجامعة we started having actually a heart failure clinic, but the problem was, and that's a very important point, heart failure clinic is extremely important, but there's a culture problem, both with the patients and physicians. They feel shy from utilizing heart failure clinic, or they don't trust the information coming from a nurse. That's a major deterrent of why heart failure clinics are not as successful in Jordan.
There is a question from Dr. Ayman. Dr. Janaka is waiting your question.
Thank you for your eloquent talk. My question is about the albuminuria, and you alluded on that. Should we be talking about, we talk about microalbuminuria, should we be really talking about nanoalbuminuria, because any albumin in the urine is a problem? My other point is SGLT1, we know it does reduce the gut-derived uremic toxins. Is there a role for SGLT1 in preventing kidney disease? Thank you.
Thank you for the excellent question. So you're correct, albuminuria is a continuous risk factor. We have cutoffs of 30 and 300 if you talk about milligrams per gram, but we know that the risk for cardiovascular disease and in particular heart failure starts at around 15 milligrams per gram. So even within the normal range, there appears to be a linear relationship. I think any measurement of albuminuria is better than no measurement. We are not doing it enough. If you do measure it and you see it is elevated even above 15 milligrams per gram, that is indicative of heart failure risk. The kidney risk emerges over 30 milligrams per gram or 3 milligrams per millimole. So that's to answer the question. There is a linear relationship, probably starting at around 15 milligrams per gram, mainly for heart failure. For kidney disease, it's generally more above 30. SGLT1 is in the gut, but it's also in the kidney. We have dual SGLT2, SGLT1 inhibition, which theoretically can have benefits. But if you inhibit SGLT1 in the gut, you also get more gastrointestinal side effects. The reason Florazin, the original drug, was never used was because of gastric side effects, because of the effects on the gut. So there are potential benefits in the gut, but there are also side effects if you target too much SGLT1 inhibition in the intestine.
Thank you. Yes,
Okay.
Dr. Raed.
Thanks. I think I will pose this question for all the speakers. There has been a lot of heated discussion about salt restriction for heart failure patients. I think it is overcooled, as I understood. So I would like to hear from the speakers, Dr. Janaka, Dr. Qais, Dr. Eyas. What's their intake on salt restriction for heart failure? Is it the way we thought it is before or not? Thanks.
Would you like to answer, Dr. Janaka?
Yeah, so I mean, I think the problem we have in the UK, which may be different to the Middle East, is that most of our patients drink too much fluid and too much salt. So low salt is a rare problem in terms of people restricting too much salt. We have a huge problem in our dialysis patients with fluid overload. And many of my CKD4 patients with heart failure also have fluid overload. So we have too much salt, at least in a Western diet. We are having too much salt. So I am a strong proponent of salt restriction because the patients I see are obese, they're insulin resistant, and they tend to have sensitivity to salt because they retain fluid. And in my opinion, salt restriction should be aimed for. It is always a balance in life, but the patients I look after are insulin resistant, obese, which have a salt retaining propensity in the kidney, which exacerbates edema and heart failure. So I would be an advocate for salt restriction where feasible, but not replacing it with potassium, because remember, many people use potassium alternatives, which obviously is contraindicated in advanced CKD.
Your comment, Dr. Eyas?
I agree. احنا بالأردن أعتقد a lot of our patients are salt sensitive, سواء hypertension أو heart failure. We generally tend to restrict their salt. والdiet تبعتنا the Middle Eastern diet is also high in sodium for the same thing. We tend to restrict it, not zero salt, but tell them to probably 2 grams of salt a day, يعني ثلث معلقة.
My second question, Dr. Janaka, is there any data on contrast-induced nephropathy incidence in diabetic patients taking SGLT2 inhibitors? Is it less, or is it the same, or we don't know?
We don't know.
The answer is we don't know. We know there is less acute kidney injury per se. So AKI, however you get it, there is less of it. Our clinical practice is caution because many of our patients tend to be dry or tend to have problems with fluids. So we pause before elective contrast, especially high-dose contrast, for 24 to 48 hours, especially metformin and SGLT2. This is not evidence-based. This is practical-based because sometimes our patients turn up from very far parts of the UK for procedures and we don't know. So we pause for 24 hours, but there is no evidence that it is beneficial or harmful in the setting of contrast-induced nephropathy or kidney damage.
Thank you, Dr. Janaka. Any question? So no more questions. I think we finish in time. I would like to thank everybody, and it is time for prayer time and lunch. See you after lunch. Dr. Mahmoud.